So good morning. My name is Steve Kareha, and welcome to the next installment of the Grand Rounds. Today we have Dr. Allison Frantz. She was a 2005 graduate, 2015 graduate of our residency program, our orthopedic residency program, and she's going to be talking today about 2014 or 2015. 2014 graduate of our residency program, and she's going to be talking today about treating the low back pain in postpartum patients. So without further ado.
Hi. So first, I want to thank everybody for coming. I know it's an early morning on a Wednesday. Today I'm going to, as Steve said, I'm going to talk about treatment of low back pain in women who are pregnant and also who recently just gave birth. There are a lot of changes that occur to females during pregnancy in order to make sure that baby is safe, mom's safe, etc. The biggest thing is I know in school, whenever it came to treating pregnant women, literally one of my professors said to me, when you're taking your boards and there's a question about contraindications and precautions, if pregnant choices, go with that. That's going to be the safest choice, because essentially we don't like to do a lot of research on women who are pregnant because we do not want to do any harm, right? That's one of the biggest things that we think about. So when I moved to the Wind Gap Medical Center, I started to notice that we have other practices within. And one of them was an OBGYN, and I was looking at our referral base and I thought, this is really interesting. And then my sister became pregnant with twins nonetheless. And she had a previous history of back pain, and she started to notice some pain and discomfort. So that's where I kind of really got some interest in this topic and started to investigate it further. So that's kind of how I got here today. So I have no financial relationships to disclose, and the planning committee has none. Today I'm just going to give you a little bit of background, identify the appropriate patient population, tell you guys some precautions, contraindications, and indications for treatment. We're going to talk about evaluation and then finally treatment of these individuals. So the biggest thing is, think about, as a physical therapist, low back pain is one of the most common musculoskeletal ailment that we treat. Well, guess what? It's the most common musculoskeletal ailment in pregnant women. And it makes sense. So depending on which study you read, it can be anywhere between 45 to 75% of women are going to report back pain during pregnancy. The biggest thing is 3/4 of individuals who are currently pregnant are going to report pain to their primary care provider, whether that be a doula, their OBGYN, their primary care physician, but only 1/4 of them get any type of care. Most of them are told this is a normal experience, it'll get better, just rest, avoid lifting, heat, ice, etc., and you'll be fine. And most of the time that is the case. But as you look further down, if you do have back pain, you're going to have a lower quality of life, increased depressive symptoms, research has shown, and about 1/4 of these individuals do take sick leave during pregnancy, again, because of back pain. The other thing is it's not always self-limiting. The biggest thing is we capture these women. Think about all the women that you treat that might have had a baby a year or two ago that are having some pain. This typically probably is not the first time that they've experienced pain. It probably actually started during pregnancy, and if we start to capture those people then when it's more acute, we can probably have more of an effect in less visits. Finally, about 25%, now the range is huge, 0.6 to 67% are going to relapse at some point during their life. And then the last statistic there is about posterior pelvic pain. Now the biggest thing is women are going to start to experience pain around 18 weeks of pregnancy, and it's going to peak around that 24 to 26 week mark. Just like in regular low back pain, we have predictors that are going to lead to a potential of increased risk factors or development of the same thing later on. Now, if you look at all of these different predictors and poor outcomes, a lot of them are actually very similar to just regular low back pain, right? So a high BMI, low job satisfaction, physical strenuous work situation, all of hypermobility, all of these are going to predispose somebody just for regular pain, but then also these are big risk factors for individuals who. So again, as I said, there's limited research out there. So one of the main theories out there as to why this occurs is because there's an increase in their lumbar lordosis, which makes sense, right? It's going to change their base of support because of where the baby's growing. It's going to put increased weight, causing them to tilt forward. Because of that, it leads to inefficient neuromuscular control, which puts increased stress and strain on the lumbar spine, pelvic girdle area. Now, just real quick, if you are getting some patients from an OBGYN, you might see some of these terminologies. So I just wanted to throw those in there real quick. Para means the number of pregnancies that have progressed beyond 20 weeks versus gravida, which means that anybody who has been pregnant at a certain time. So for example, you might see that there's a female who is P1 but G2. That means that she has one pregnancy that has progressed beyond 20 weeks, but she did have one miscarriage. Lightning is when the uterus drops. This allows the woman to breathe a little bit better. Some research says it's around 40 weeks, but that's really the end. I've also seen around 36 to 37 weeks, you can start to drop. The final thing, most people say, oh, pregnancy lasts 9 months. That's a lie. Don't listen to them. It's 40 weeks, so do the math. There's 4 weeks in a month. That's actually 10 months. So it actually makes more sense to break it out by weeks. So you have your 3 different trimesters. First, second, and third, week 1 through 13, 14 to 27, and then 28 to 40. Now, just because you have 40 weeks, that doesn't mean you're going to go to 40 weeks. Around 38 weeks is going to be full term, 38 to 39 weeks. All right. Now here's when some things start to get important. So when we're treating an individual who is currently pregnant, we have to think about all the changes that her body goes through. One of the biggest things is mommy brain. So no, mommy brain is not a lie. It's actually true. So there is changes. The brain actually gets smaller. One of the biggest thing is mom is diverting a lot of her energy, a lot of increased fluid, blood flow, etc. to the baby. So that's going to take away some of the cerebral spinal fluid, leading to some of that shrinkage. Also, there's a lot of other hormones that are coming out. So progesterone is one of these huge hormones that you're going to see a theme throughout this presentation. And it actually has a sedating effect. So it makes verbal recall processing speeds a little bit slower. So because of that, when you're giving somebody a home exercise program, make sure you write it down. I know a lot of your patients sometimes will be like, no, I got that. That's fine. I have it. Especially somebody who's pregnant, write it down because there's a chance that it's going to get, they can take in some stuff. If you think about your regular cognition, you can hold, your working memory can hold 4 to 7 things at a time about, simple. Think about phone numbers. That's why they're as long as they are. But somebody who's a little bit slower and not processing fully because a lot of their time and energy is being diverted to baby, you're going to want to write that down just in case. All right. This is just a quick slide giving you an overview of all the other systems that we're going to quickly touch on that, again, are going to change, which are going to be important and help you determine your treatment. So I always say whenever you work a muscle, think about your bicep. If you work your bicep's going to get bigger. Well, the heart's going to work harder, so the heart's going to get bigger. Increased in heart rate. You're going to have increased blood volume. When you have increased blood volume and stroke volume, that means your cardiac output increases. Now think about it. Cardiac output is stroke volume times heart rate. Your stroke volume is increasing by 25% and your cardiac output's increasing by 20%. Your stroke volume is increasing by 25 and your heart rate's increasing by 20. So essentially, your cardiac output's going to increase by almost 50%. The other thing that increases is blood volume, blood plasma, and red blood cell. Again, we have to get all these nutrients to the baby. So what does this matter for us? Well, guess what? We're going to have somebody exercise. It's going to increase their heart rate. So if their resting heart rate is already increased, that means that your 220 minus age or anything like that might not be efficient to figure out a target heart rate. You're going to have to go back to your Borg's rate of perceived exertion scale in order to determine if you're hitting what you need to do. The other thing that you want to watch out for is there could be the potential for pseudoanemia. Because there's the increased demand for blood, mom needs more iron, and that might not be available. So in the beginning stages, if not supplementing with iron, that could be another big thing to look for. The other thing that you want to look for is changes in like that postural hypotension type of thing, dizziness, nausea, lightheadedness, anything like that. Systolic blood pressure is going to remain the same, but diastolic blood pressure is going to increase by about 10 to 15 millimeters of mercury by 24 to 32 weeks. So that's going to be important when you're taking blood pressure. It's going to be nice to assess blood pressure pre and post exercise because, again, think of all the things that are changing in the cardiac system. The other thing is you want to watch out for positioning. So in the first trimester, you're okay to have them lie supine, but as you can see in this picture above, that's the inferior vena cava. And after the second trimester, if you're lying supine, some people are going to get some really big postural, supine postural hypertension syndrome is what it's called, because the baby starts to press on the inferior vena cava and blood flow cannot get back to the heart. So it's going to be really important that you have these women lying recumbent or slightly in a left lateral position where you kind of prop some pillows underneath their hip to avoid anything like that. And again, the supine hypotension syndrome, as I mentioned, faintness, lightheadedness, dizziness, nausea, agitation, and even possible syncope. Now, because we've increased blood flow, kidneys have to work harder. Erythrocytes are going to increase, just like I said. Mom needs more iron. And then finally, plasma fibrinogen is going to increase. So that means there's an increased risk of clotting. So make sure that you have your Wells clinical DVT rules out, because Wells also has a PE rule out. This way, you can look for signs for any DVT or PEs. Oops, sorry guys. Now, whenever there's a change in the cardiovascular system, since the respiratory system works hand in hand in this, the respiratory system is also going to change. So most of these should make sense. If you have an increase in red blood cells and everything that goes along with it, you're going to have an increase in oxygen consumption, right? Now, again, here are these hormones, progesterone and estrogen. You're going to hear me talk about them a lot. Progesterone always relaxes smooth muscles. And it doesn't just relax smooth muscles in the reproductive system where mom needs it. It has an effect throughout the whole body. So this is going to relax the smooth muscle in the respiratory tract and increase the ventilation. So resting respiratory rate is also going to be slightly increased. Estrogen is also going to lead to increased vascularity. So there's an increased risk for nosebleeds, vocal changes, any like sinus or nasal stiffness also, which you might notice. Mom might complain of that. You can suggest throat lozenges, gum, or increase small frequent meals to kind of help with that. The other big thing, the diaphragm. It lifts by 4 centimeters, especially towards the 3rd trimester. So you're going to breathe more thoracically than abdominally, and it makes it harder to breathe. So shortness of breath comes on much quicker. It's going to be more laboring and taxing to do so. Also, again, I'm going to show you a picture actually in the next slide, so I'll talk about it there. Your lung volume is going to decrease. This was the best picture I could find, so I apologize, guys. Right here, you can see, obviously, this is just your normal anatomy. Here is somewhere around the 3rd trimester. But so first of all, look at the diaphragm. The diaphragm is right above the liver. So you can see how much the liver changes, but the diaphragm kind of goes from more of a C shape to even more kind of a flattening shape. Look at the changes in the lungs and the size of the heart. Again, everything's getting pushed up. The other thing to take note of is the stomach. So the stomach is right below the liver, right? And then finally the bladder, which is the yellow right there. So these are all things that are going to change because there's not a lot of real estate. So we have to make real estate for baby to grow. Okay, so that was the cardiac and the respiratory system. Let's talk a little bit more about the endocrine system. Again, I've been mentioning some of these hormones to begin with. So one of the biggest things is the placenta and the uterus are going to be your primary hormone-producing gland. The thing that we want to watch out for is you want to make sure that the thyroid gland, you want to watch out for hypo or hyperthyroidism. The reason for this is because the thyroid hormone is extremely important for brain development, so you want to make sure that there is any issues. Now, you can see 25% of pregnancies, the woman actually has hypothyroidism. So you want to watch out for anything because hypothyroidism can lead to some complications, and those could include pregnancy-induced hypertension, abruption, postpartum hemorrhage, low birth rate, and possible neural development issues. The more important one is hyperthyroidism. This is much less common, but it can really lead to some significant complications in baby. And what that means is there's an increased risk of stillbirth, preterm delivery, intrauterine growth restrictions, preeclampsia, and heart failure. So these are all things that you want to look out for, right? So we all know the general signs of hypo versus hyperthyroidism. Hypo means a slowing, so increased fatigue, they're gaining weight, etc. Versus hyperthyroidism, they're kind of bouncing off the walls, very agitated, sweating, that kind of stuff, because you think about hyper versus hypo. So it's something to keep an eye on and look at and monitor. Gestational diabetes is also a really important thing to think about. So in the 2nd trimester, the baby needs more glucose for fetal energy, so that's when women are more predisposed to developing this. And if you have gestational diabetes in one pregnancy, 41% of individuals have it again in their subsequent pregnancies. Exercise and diet can definitely significantly reduce this risk. The biggest thing is what will happen is there's not enough glucose available for mom and baby, and that's what leads to it. So the important thing is hypoglycemia can occur between meals, again, especially in the 2nd trimester. So if you're treating these individuals, look at time of day, look at when they ate, and make sure you have small snacks in the clinic to make sure that they don't start to get a drop in their blood sugar. All right, so I just really quickly want to touch on some of these hormones. You're going to have to bear with me as I say some of the names of these hormones. The first two, HCG and HPL. So HCG is human chorionic gonadotropin, which is produced early on in pregnancy, and this is what gets the progesterone and estrogen going. This is what gives you your positive pregnancy test, and once the placenta is developed, that starts to take over. Your HPL is human placental lactogen. Again, this is going to be important for gestational diabetes. It increases glucose availability, allows for actually metabolizing free fatty acids so that there's enough energy available for baby. This is only during pregnancy. Now, the important ones that we're really going to talk about a lot more throughout this presentation is estrogen, progesterone, and relaxin.
I don't know much about
Relaxin, progesterone, and estrogen are all available regularly.
So
The relaxin isn't just at the end, which is going to be really important. So estrogen obviously is going to aid in developing of the ductal system, breasts, increase production of normal. Greg keeps talking. And then progesterone is going to relax, thanks Greg, is going to relax smooth muscles.
Me, Greg?
Yeah, you, Greg.
Which, again, as I alluded to earlier, it's going to have an effect kind of all throughout the body. Again, it's going to stimulate increased ventilation. It's going to prevent tissue rejection, facilitate maternal fat stores, stimulate breast tissues, has a big effect. And then relaxin is going to help relax the pelvic girdle so that the pelvis increases in space so that baby can pass through the birth canal. But again, relaxin is present from the beginning, and it's going to have an effect not just in the pelvis, but in all joints, which are going to be really important if we're doing any type of strength training. Now, the other thing is I talked about estrogen, it increases to increase vascularity. So guess what? In the integumentary system, there's going to be increased blood vessel dilation and proliferation. There's going to be increased blood flow. That's going to lead to increased sweat and sebaceous gland activity. It's going to be much harder to disperse heat. So they might get overheated very quickly. So make sure it's a cool, comfortable temperature. They have very cool, loose-fitting clothing. It's going to be really important. And then the other thing is skin needs to stretch. So there might be some itching from the collagen kind of breaking apart. Your gastrointestinal system, again, same thing. You can see that you can have gingivitis and bleeding gums, tylocism, which is excessive salivation. Again, this could be with gum or something like that can help it, but that's because of estrogen. It's leading to that increase in vascularity. Things are moving more. The other thing is progesterone is going to relax smooth muscle, so it's going to lower your esophageal sphincter tone, which could lead to more indigestion or heartburn. Same thing. Remember the picture from the beginning where I showed all the changes in your internal organs as baby grows? Well, the stomach is moved upward. It's displaced. So because of that, it's closer, and there's, again, that's also a big reason for heartburn, just because of the change in the stomach, upward displacement of the stomach. That's the word I was looking for. All right, so I'm sure most pregnant women can relate to this. A pregnant baby hugging the bladder, saying, "Mama," you know. But again, we have this increased urinary urgency and frequency. But part of this makes sense. If the kidneys are working harder because we have increased red blood cell, plasma, erythrocytes, etc., then it's going to produce more waste. The other thing is, as baby's growing, baby's also metabolizing and producing waste. So we need to excrete that. So that's kind of what happens with the urinary system, why there's increase in urinary urgency and frequency, which will be important, making sure that you're providing proper bathroom breaks, but also making sure that mom's getting enough water throughout. And the capacity actually doubles even though it's nice and squashed. It can actually hold double of what it is, but you're producing for 2. So finally, what we all came here for, the musculoskeletal system. So there is a significant increase in demand for calcium because the baby's musculoskeletal system needs to start to develop and grow, not to mention many other things that calcium leads into. So it's going to be really important, especially towards the end of pregnancy, that you have an increase in calcium and calcium supplementation is occurring. There is a risk for transient osteoporosis during pregnancy, which can be really, really important for us. There was actually a case study back in 1998. It was pretty old, but there was actually a case of a femoral fracture from transient osteoporosis during pregnancy. So it can happen, it's out there. Just make sure that you're looking for signs of that, deep pain, constant, all the time. The big thing that's really going to be for us to work on is postural changes. So The changes are progressive. They don't happen overnight because the baby grows over time. It doesn't take, it doesn't grow overnight. And all of these things, as mentioned above, are going to lead to some of these changes. So as you can see in this picture here, on your left, this is the one where it's just kind of normal, how you would normally allow yourself to just kind of hold your posture. In the picture on the right, she's actually doing a posterior pelvic tilt. So you can have some changes and effects on the posture, but as you can see, there's going to be that increased curve, an anterior pelvic tilt, bigger base of support. You're going to externally rotate your hips, some genu recurvatum, some foot pronation, and there's also going to change in pressure on your foot. So all of these things could lead to pain not only in your back, but in your hip, in your knee, in your foot, anywhere. Because again, when we affect one area of the chain, everything's going to kind of counteract that way. And it's going to be really important as you're treating these individuals to not only look at just the spine and stay hyper-focused, but kind of look all throughout to make sure that we can have a full effect on them. So diastasis rectus is actually more common than most people realize. So it's a separation of the linea alba and the rectus abdominis muscle. And again, it's because the skin and the muscle tissue needs to stretch in order to accommodate growing baby or babies. So there are different degrees of separation, and it really depends on what happens. Now, as you can see, recovery usually plateaus between day 1 after delivery to week 8. But the problem is there's actually, there was a recent study showing that 50% of women that presented to a urogynecological exam, so that means that they actually have some women's health issues, some stress incontinence, urinary incontinence, etc. I'm not going to touch on that right now. That's not my bread and butter. But they actually had that after a year after greater than after a year after pregnancy, they had this continued persistent diastasis rectus that was actually leading to most of their dysfunction. The biggest thing about this, though, is these are women with higher increased maternal age. So their average age of the woman presenting with this complaint was around 54 years old. So the diastasis rectus was actually probably much older than just a year out. There were a few that were younger, about a year out. Research-wise for PT, there's really poor and insufficient evidence that PT can actually help improve a diastasis rectus. But that's only because I found like 3 or 4 studies, very low quality evidence, and the sample size was just not that great. They had positive trends toward, but there just wasn't enough power in the study to actually get a statistical significance. Okay, now I'm just going to quickly touch on some of the other common MSK disorders, musculoskeletal disorders that can occur. So you can get thoracic outlet syndrome or carpal tunnel. Carpal tunnel, you're going to have fluid retention, so a resting night splint actually can be really, really effective for women. For the thoracic outlet syndrome, you have postural changes. It's going to change first rib position, and that's a huge part in thoracic outlet syndrome. You can also have any of those hosts of diagnoses up there. And again, what exactly they're going to lead to, what's the underlying pathology, is going to depend person to person. But the biggest thing is you can have these small subclinical issues that really don't bother you beforehand. Maybe every once in a while your knee hurts or something like that. But when you become pregnant, because of all of the changes that you're undergoing, not only to your musculoskeletal system, but all other systems, it can lead to this clinical issue where these women could be presenting to you with pain. So now we're going to quickly, again, I want to spend most of the time going over lumbar, SIJ, pelvic pain. But again, you can see all the host of different things that can occur just during pregnancy. A lot of them are because of postural change. Jaw pain, your TMJ dysfunction can be because of increased stress, grinding your teeth at night, etc. We talked a little bit about diastasis recti, but that can start in the 2nd trimester as you start to kind of grow and expand a little bit more. And then your rib dysfunction can occur. Think about it. The ribs are going to flare up and out, which can lead to some thoracic pain and dysfunction. Symphysis pubis. It's separating, right? You can have a symphysis pubis dysfunction. The coccyx can fracture during childbirth. So this is going to be important for women that you're seeing after birth. That could be some of their pain, especially with sitting. Pelvic girdle pain is actually going to affect 1 in 5 women, and it might become chronic in 1 in 4. If you have pelvic girdle pain, you actually have lower you tend to have lower quality of life and increased disability afterwards, and it tends to affect you more so than if you just have back pain during pregnancy. So, just like with normal sacroiliac joint dysfunction, there's always risks for developing it. Both of them are kind of similar. You can see a bilateral versus a unilateral. Multipare means multiple pregnancies. Prior salpingitis means inflammation of the fallopian tubes. And as you can see, Any prior low back pain, any trauma, any traumatic childbirths, this can all lead to it. But then some of these are going to be more kind of intuitive: poor spouse relationship, low job satisfaction, increased stress, lower education and socioeconomic status, etc. This is just kind of a summary back to what I talked about before. 45 to 75% of women are going to have back pain during pregnancy. We have postural changes that occur. Women who are physically active are going to have lower pain scores. So that's something to keep in mind, because guess what? We can get women physically active and safely physically active. So a woman presents to you with low back pain. She is, we'll say, 26 weeks along. You're going to do an exam. You want to make sure that you're screening for your red flags. You always, always, always want to screen for red flags. So these are going to be more specific for pregnancy. So you want to watch out for polynephritis. Now, the kidneys are working harder because they have to take on more fluid. So you want to make sure there's no infection. So you're going to look for fever, urinary frequency, urgency, nausea, vomiting. Okay. The other thing you want to watch out for is preeclampsia. So preeclampsia is pregnancy-induced hypertension. It's also marked by calcium in the urine. This is hypertension in someone who doesn't normally have hypertension. So that's why it's going to be really important to monitor blood pressure. It usually occurs around 20 weeks, but it can occur slightly later. But if it's untreated, it can lead to eclampsia, which can be really, really detrimental to both mom and baby. The other thing you want to watch out for is any severe abdominal pain, vaginal bleeding, decreased fetal movement, and symptoms of a DVT. Remember, you have increased clotting factors, etc. You want to watch out for that. And then the severe lower abdominal pain, vaginal bleeding, and decreased fetal movement could be all issues with baby. So if anybody presents with any of that, that's a referral out. The other thing that you always want to screen for in every single person: depression, suicide. Remember, I said about femoral fractures, there is a risk for osteoporosis, so you want to make sure that you're screening for that. Cauda equina, cervical myelopathy, abdominal aneurysm, atypical MI, cancer, etc. Just your normal red flags. You always want to screen for that. And then when you're doing your exam, you want to make sure that you're not putting mom or baby at risk. So nothing that's going to lead to loss of balance. Do not have them lie prone after the first trimester, unless there's something actually legitimately called the Prego pillow, which is this huge thing somebody can actually lie prone in, and safe, no issues. Supine, again, if they have that supine postural hypotensive syndrome because of the compression on the inferior vena cava. Anything that's going to significantly strain the pelvic floor or abdominal muscles, vigorous hip adductor stretching, and anything that may cause overheating. So, when you do your examination, remember your orthopedic exam. I just gave you all your contraindications, your precautions, what you need to screen for. Essentially, then it's up to you to watch them move, do your special tests that are appropriate, and then treat them from there. Because then you're going to put it all together. So, for example, if you're going to look at the SIJ, this isn't a comprehensive list by any means, but just something I kind of threw up there that you want to look at. Symmetry, I put a question mark, because we always know that if you're palpating for symmetry, there's really poor statistical evidence for that, but it's going to be important to still palpate for it, right? The other thing is you have your SIJ provocation clinical prediction rule. Well, guess what? One of the clinical prediction rule that has more sensitivity and specificity, it includes the sacral thrust, which you have to lie prone for. Well, you can't lie prone for that. So the other things that are in it are the thigh thrust, compression, distraction, and Gaineslands. You need 3 out of 5 positive tests to have 0.91 sensitivity, 0.87 specificity. So if you get the first 4 positive, do you have to do the sacral thrust? No. The other thing is there's another clinical prediction rule, which is great. There's distraction, compression, favors instead of the sacral thrust, Gaineslands, and the thigh thrust. That one has a little bit lower sensitivity and specificity. It's 0.85 and 0.79. But 3 out of 5, you get that positive. You can say that this person has SIJ pathology. And again, you're going to do your strength testing. You're going to look at your muscle length. You want to look at functional observation, etc. That's all going to be important. For back pain, same thing. You want to look at active range of motion. Again, be safe. If mom's going to have an issue going into forward flexion, Okay, then, don't have her really go into forward flexion. Have her hold on, safe, simple, easy. But the biggest thing is what's going to be more important is what is the quality of movement. That's going to tell you more than the actual range of motion sometimes, especially, if you can't go through the full range of motion because there's a baby. You are going to palpate. Posture is going to be one of the biggest things that you're going to do on your examination, especially for back pain, because that's where a lot of this issue is stemming from, is the postural changes that do occur. Always do a neuro screen, looking for any type of radiculopathy, anything like that. And of course, your differential diagnosis, you're going to do your hip clearing tests, your SIJ clearing tests, etc. One of the things you can think about is if, again, knee hyperextension, genu recurvatum, that's one of the common things that's going to happen when they're standing. You can ask them just to soften their knees by flexing them a little bit. That's going to limit the amount of pronation that occurs, which could take off some pressure and stress. Also, just by doing a simple posterior pelvic tilt, that could provide mom with a lot of relief. So we can have a pretty big effect just within a few visits. So you did your evaluation. You looked at everything, figured out what was going on, where the strength limitations are, where the postural limitations are, etc. What are you going to do? Well, obviously there's going to be some contraindications to treatment. So let me talk about the bottom ones before I talk about the first one. No ultrasound, no mechanical traction. Sorry guys, you can't get out your diathermy machines. You want to be careful again with prone unless you have that fancy prego pillow. And then supine, again, if it's after the first trimester, that's when you're going to worry. But again, you can position in slightly recumbent position. It's just like somebody who might have, a cardiac issue who cannot lie flat. It's going to be the same thing. We're going to prop them up with some pillows and a wedge. The other thing to keep in mind is always watch for early signs of labor, like a bloody show, contractions, frequent and stronger, and their water breaking. So you always want to watch out for that during treatment. Now, electrotherapy, there's some controversy out there about that. Some sources say that it may cause uterine contractions. Others say it's actually preferred over pain medication, because you don't want to have somebody taking pain medication when they're pregnant. So what the authors of a couple systematic reviews actually suggested was that you try it, but monitor regularly. Now, if it's a cervical issue, that should be okay. Lumbar, same thing. You use your clinical decision-making. Think of what you want. The uterine contractions occurring was older research. Newer research is starting to say that it is preferable to pain medication. So again, use your clinical judgment, monitor if you're going to use it. So, treatment. There is moderate evidence, this is me being very gracious about the evidence too, that physical therapy can decrease pain, improve disability and sick leave. We want to treat the impairments. Now remember, this is something that's progressive. It's not something that's going to stay with them over time. After giving birth, hormones tend to stay elevated for 6 weeks. Now that's also going to change depending on if mom is breastfeeding, and just overall her anatomy, physiology, etc. So there might be some give and take in that 6-week mark. So it's going to think about the progesterone, the estrogen, the relaxin, all that stuff is still going to be coursing through her if you see someone that's 2 to 3 weeks after birth. So with that being said, as you're moving forward and treating these individuals, it's going to be really important still to remember everything that we talked about, but put it all together. You want to make sure that we're not seeing these women 5 years down the road with back pain. Because, again, food for thought, think about how many women are on your caseload with back pain who have children or multiple children and have kind of had some back pain for a while, and it's just slowly over time getting worse. It's what's the cause of the cause. It's these slow, little, continued stresses over time accumulate to one big stress and irritation. So that's kind of another reason why I got interested in this, is because this might be a nice place to kind of get women early on to make sure that further down the road, there's not more pain also. So what are you going to do? One of the biggest things, functional treatment, ergonomic training. Most women have more than one baby. Most women have very heavy diaper bags. I can tell you from experience, changing tables are at a terrible height for anybody. Again, because you're kind of flexing forward, I'm going to show you that in the next picture. It's going to be super important because you don't want the pain to come back. And as you saw in the beginning, anywhere from 0.6 to 67% of women have a recurrence of their back pain. Now, the other thing, stretching and strengthening. The ACOG, which is the American College of Obstetrician and suggest about 150 of moderate intensity aerobic exercise each week. That's about 30 minutes 5 times a day. I'm going to talk a little bit about manual therapy, yoga, and I should have switched that. So that's supposed to be acupuncture, not Pilates. And the only plug that I'm going to say about aquatic therapy was that there was one study that I found. Again, it was one study. It did have a significant effect, but it had a very low sample size, poor quality. It was more kind of like a pilot study that aquatic therapy can actually be very helpful for women. So again, make sure that they're doing things right. Treat the underlying issues, the dysfunctional movement patterns. Spend time on function and ergonomics, that core control, setting your core. As you can see, here's a picture of a changing table. She's kind of forward flexed like this. Now, my sister has twins. So you change one, you dress one, pass one on, the next one has to come and get dressed. So you can be there for 5 to 10 minutes. I am in no way a changing diaper expert, so it took me 5 minutes just to change one diaper when I first changed a diaper. But think about it, I literally was there for 30 seconds and I was like, this isn't gonna work, I need a chair or something. Because again, you're putting a lot of stress and strain on your back. Not only is mom doing that, dad's doing that, grandma's doing that, anybody who's helping out. Again, I'm just gonna say it for like the 5th time, make sure that you're treating them function and ergonomics. It's going to be super, super important for them further on down the road and to continue that we don't get these repeat patients. Exercise can be really, really great for mom and baby. As you can see, it can improve fetal development, easier labor, less risk for gestational diabetes and other complications, decrease in back pain, improve body image, better psychological well-being, and improve weight management. So how are you going to exercise? You want to focus on core strength. Again, think about it. The change in postural is going to make inefficient muscular control. So you want to make sure that the core is nice and strong. You're also worrying about stretching of some of the core musculature. So you want to do more static versus dynamic exercises. Now, the author of this research study, particularly that I'm going off of, the biggest thing, as he said, was, you want to focus on whole body also, because you don't want any pooling. You don't want to do a split routine. So it's definitely worth it to incorporate your core control as you're doing upper extremity or lower extremity exercises. You want to keep your weights low, avoid Valsalva maneuvers as always, and avoid excessive forward flexion, so excessive and forceful forward flexion after the first trimester. Joint laxity does occur during pregnancy because of relaxin. Gotta love relaxin, right? Make sure that you're not doing excessive weight, which can be detrimental. That's where it's less than the 70% of your 1 rep max. Now, there is some literature out there that states about elite athletes who get pregnant. The biggest thing with exercise is you do not want to improve your exercise tolerance. You want to maintain or stay steady. So say, for example, the Olympics was just on. The most recent event I watched was the marathon. You're a marathon runner. Mom can continue to train and run, but you're not trying to improve where you were at before you got pregnant. You're trying to maintain it. That's going to have less harm. Again, it's really going to be dependent on you, and make sure that consult the doctor. Okay. So here's some ideas of stuff to do, but ultimately you're going to look at mom and baby, see where they're at, see what they need, and you're going to tailor your treatment from there. Quadruped's going to be a great position, especially if they can't do any flexion. It's going to be nice, good for core control. It's not going to put them in any harm. You can do some planks or side planks if they feel comfortable with it. It might be challenging as pregnancy progresses. Anything that you can do, just utilize your toolbox. Know the precautions, the indications, the contraindications, and go from there. Now, here's some research about exercise. This is from a recent Cochrane review, actually. And the biggest thing that I'm just gonna sum up this slide for you. There is anywhere between moderate to low evidence for treatment of low back pain, or the combination of low back pain and pelvic girdle pain in pregnant women. Usually the combination of exercise and a support group seem to help, but the biggest thing that they tend to compare to is prenatal care. So during prenatal care, you actually are getting ergonomics, very quick ergonomics, some postural tips, etc., just from your OBGYN, or if you have a doula or anything like that. But it's nothing extensive. A lot of these either did not find any statistical significance, or they just had a really low sample size. Specifically, there's a 12-week program that they did supervised exercise versus a control group. Now, they did core control, upper extremity, lower extremity strengthening. All these women did have low back pain. And they found that they began around 20 weeks of pregnancy, That's when they started to recruit anybody that was 20 and about, I think, to 24 weeks. And then they collected data right at the end of the 12 weeks, again at 36 weeks, and then 6 weeks after delivery. And they did find that the training group were significantly less likely to report pain, but more importantly, 6 weeks after delivery, they had significant less pain. It had no change in disability, but it did have improved functional scores. So this is just kind of one of the better studies that shows that exercise can be important. Now, the difference between this next study is instead of doing an individualized program, they did a group program where they had group exercise. Everybody did the same exercise. They then did a home exercise program that only lasted 4 minutes. So it was like 3 very simple basic exercises. And they did it once a week for 60 minutes, or I'm sorry, twice a week for 60 minutes. There was a trend towards improving pain in this, but it did not significantly lead to increase in low back pain or pelvic girdle pain. Again, pelvic girdle pain tends to lead to more disability than low back pain, just kind of like what I said before. But what the authors really suggested in this paper from looking at the literature is that an individualized program is going to be more effective and better at treating women that are pregnant than a group program. Again, it's nice for the support group and friends and being able to talk and see how the pregnancy is going along. But specifically for back pain, it's going to be better for that individualized treatment so that we can tailor and adapt the program for each person to individualize it. Gupta et al. Did a small study. There's about only 40 individuals in this study, but she also looked at just an individualized treatment program that did upper extremity, lower extremity strengthening and stretching versus the upper extremity, lower extremity strengthening and core stability exercises using like a physio ball, quadruped, planks, etc. And she found that by the addition of having those stability exercises, there was significant improvement in pain. All right, let's talk a little bit about manual therapy. PTs are really lacking in this category. The osteomanipulative therapists, the OMTs, have much more research. There's moderate quality evidence that OMT can be more effective during pregnancy than standard care alone. This was also compared to a sham ultrasound, which was also just as effective. So, use your clinical decision-making skills when you kind of think about that study. There was one study that looked at the combination of exercise, manual therapy, and education. Again, it was a low sample size, which is why it's more of the low quality. But what they did was more kind of massage soft tissue. If there's any pelvic obliquity, METs are great. They can really, really help. And you just have to be gentle. They don't have to be forceful contractions. We can do some gentle METs just to kind of help realign the pelvis. Again, there's relaxing. There's going to be some movement in there, which can help individuals with low back pain and pelvic girdle pain. Here's another study looking at osteomanipulative therapy. This is for postpartum women. So they had an osteomanipulative evaluation. An OMT evaluated them for 3 treatments at 2 weeks postpartum, 4 and 6 weeks. The control group was placed on a waiting list, but pain reduced from 7.3 to a 2. What they did in the osteomanipulative therapy was they evaluated. They did any joint mobs or grade 5 as indicated. And then they also did soft tissue work, postural re-education, and neuromuscular re-education. So that's kind of what we do. So just something to think about. But again, overall, there's limited evidence because of poor quality designs, low sample size, etc. Now, Field et al. In 2012 looked at the combination of yoga and massage and actually found a pretty significant improvement in all of those depression, anxiety, back leg pain, relationship scores, and increase in gestational age and birth weight. So with manual therapy, use your judgment. Again, we know that the postural changes aren't going to be forever. I think that there's going to be some kind of effect because how many women do we see that do have an anterior pelvic tilt? But it's something to consider as you're moving forward. There's more evidence for exercise, so keep that in mind too. Alternative medicine, there's not great evidence about acupuncture, but there is pretty good evidence for yoga. So a 10-week program of yoga actually led to some significant reduction in pain and actually negative pelvic provocation special tests. So this might be nice to kind of refer mom for some gentle maternity yoga or something like this and on top of their exercise. And this could be one of their aerobic exercises that are recommended. Support belts. Again, there's some evidence out there about that. One of the continuing education courses that I took really liked the mother-to-be belt, which is what's pictured above. again, this can just really help offload some of that paraspinal musculature in the low back to kind of help as pregnancy advances, because again, baby's not going to be in there forever. But there's kind of low quality evidence, and there's a debate versus rigid versus belts versus more of a less rigid belt. So when you're going through exercise, there's always contraindications. All of these tend to make some sense. So if you have any high blood pressure, ruptured membrane, premature labor, anything like that, poor fetal growth, incompetent cervix, placental disease, or history of miscarriages or premature labor, you're not going to want to do exercise. Relative is if your mom has extremes in weight, a sedentary lifestyle, history of poor fetal growth and rapid labors, bleeding early in pregnancy if they're breech, any cardiac issues, and anemia. And then there's some just kind of additions from the ACOG. Restricted lung disease, heart disease. I'm going to say this wrong because I do it every time. Circage is when they sew the cervix. But then again, if you have, chronic bronchitis, you're a heavy smoker, poorly controlled hypertension, seizure disorders, hyperthyroidism, type 1 diabetes, and anything like that, you're going to be careful with your exercise. Signs to stop exercise, again, some of these should make sense. Vaginal bleeding, significant dyspnea, just shortness of breath prior to exercise. Dizziness or headache, you're going to worry about some of your red flags. Any chest pain or a recent onset of muscle weakness. You want to look for DVTs, any preterm labor, decreased fetal movement, and amniotic fluid leakage. If mom wants to scuba dive, sorry, she can't. She's going to have to wait. Water skiing, they also want you to avoid. Any downhill or cross-country skiing, high-altitude activities. But again, this goes back to what I talked about with elite athletes. They have to get it cleared by their doctor. If they've been doing it prior to pregnancy and they're going to maintain a level of fitness and they can do it safely, most of the time the doctors are probably going to say that's okay. But if mom wants to take up scuba diving at 20 weeks, you're going to have to tell her no. So the bottom line, the reason why you listened to me drone on for the past 50 minutes is because you guys wanted to be able to effectively treat anybody who came to you who is pregnant or within 6 weeks out of pregnancy. There is limited poor quality evidence, but again, part of that is because there's just not a lot of evidence out there, because it's kind of one of those things where you do not want to do harm, so people tend to just say, okay, we're just going to put them in this group to the side, they'll be fine, it'll change when the babies are born. But the biggest thing is, if, again, think about your caseload, think about all these people that you see, all these women who do have back pain further on down the road, that it might have started to present while they were pregnant, and then it kind of persisted over time, and they just kind of ignored it because they're so busy. They're taking care of a baby. They might have other kids. They have jobs. They have families. So they kind of just brush it to the side until finally it gets to the point where they can't take it anymore. I know there's a bunch of women that I've seen with newborns that are, anywhere between 6 months to a year to 2 years old. So I think it's really important to kind of start to recognize this population more and start to kind of market our services to say, hey, they might only need 2 or 3 visits just to give them some functional ergonomic training, some core stability exercises, and then as long as they stay regular with that, they'll be fine. So utilize your toolbox, remember and understand the precautions and contraindications, and just understand the changes that occur during pregnancy and treat the impairments. You'll be able to get them better and feel much better. Questions? Those are my nephews. Any questions? Yes?
Could you elaborate on the contraindications for miscarriage?
Yeah, so the biggest thing is if you have a history of a miscarriage or premature labor, it's most likely going to be multiple miscarriages. So this is somebody who's having trouble getting pregnant and has miscarried multiple times. They're going to want to be as safe as possible. So they tend to err on the side of caution because they don't want you overly stressing your body or taxing your system for a baby. Because exercise, it does all those things. It's going to shunt blood away from the placenta to the muscles. It's going to shunt blood away from the away from your gastrointestinal tract. It's going to go away from the placenta in order to go to the muscles to disperse everywhere. So obviously, if you have a history of miscarriages and it's early on during pregnancy, they're going to want you to hold on that exercise because they want to make sure that you're not going to do harm to baby. Does that answer your question? Yes.
You talked about marathon runners and pregnancy.
Yeah.
Is there a period of time when they have to stop If you are a weak runner, if somebody's doing a marathon, is there a weak number that you must stop running?
That's a great question, and I'm not sure of that answer. The reason for it is I'm sure it's going to depend on the woman, what the pregnancy is, what her age is, what the health of the baby and the woman are, and it's going to depend on her and her doctor, what they feel comfortable with. But I'm sure as pregnancy also advances, they're not going to want to be running long miles. But again, I know I've known people who did run pretty late into their pregnancy.
We have some acute care therapists here,
Mm-hmm.
and just help me out here. What we've seen, we get consult with patients in the OB,
Mm-hmm.
and they have remnants in their severely bariatric.
Mm-hmm.
So that causes a lot of problems. So it causes all of this interstate tenfold. What we've also seen, and I don't know if it's happened recently, but we've seen kind of a pseudoparalysis.
Mm-hmm.
So we're faced with that situation. So then you're limited by the walls of the hospital.
Mm-hmm.
So any advice you can give to the acute care therapist for those two complications? So we have this high BMI, and you have this pseudoparalysis. So
Yeah.
it can't get long.
Mm-hmm.
So,
Pseudoparalysis of what? The one whole lower extremity? Okay. So again, that's when you're going to go back to think about your acute low back pain or some of your chronic low back pain, or just starting to get into exercise. You just simple, start with some TA contractions. Start with maybe some, if you can do like a straight leg raise or a double, like TA contraction with double limb stance. Put them in sideline, work on some pelvic and core control, do some clamshells or something like that to help improve them. The other thing that you can do is, again, they're not going to probably be able to, if they have the pseudoparalysis, which is actually very common, that's the nerve dysfunction that I talked about. It's the fluid retention and some of the change in the posture that can lead to transient like femoral nerve or some type of neuropraxia. So again, pelvic floor contractions are going to be really good, just nice and gentle to support the whole core. If you can get them sitting at the edge of bed, you can even do some more core control where you're kind of doing some gentle kind of abdominal isometrics, or isometrics with marching. You can work on anything from there just to kind of help decrease and position them. The biggest thing is everybody's so different. Sometimes the bariatric is just a whole nother complication. But if you're even able to, well, I guess we don't have any sling supports, because even some like gentle bodyweight support or something like that could be very helpful too. You can also recommend the pelvic belts or stability supports. I've also used kinesio tape to see if a pelvic support might be helpful. My sister is towards the end of her pregnancy, and she said, every time I hold my belly like this, I feel much better. So I literally took 2 pieces of kinesio tape, just pulled up and this way, just to kind of add a little bit of support and remind her to kind of stand up a little bit taller. And that actually significantly offloaded a lot of her back pain during pregnancy. So that might be something to think about too. Again, I don't think it was anything taught at a course. It was just something that, yeah, I was talking to one of my fellow PT friends, and she had somebody who was also pregnant who said the same thing, and we kind of were just like, oh, well, what if we just take some K-tape and go like that, and it felt great. Any other questions? Yeah.
I've never seen a Prego pillow, but is that something that would be useful, might be useful in the clinic?
It might be. The problem is it's super expensive, and it's really, really big. Yes, but fair enough. If you are seeing these women regularly, I would heavily suggest having it in the clinic. And I think at Center Valley you guys have some women's health, so it might be something to look into investing. But literally, it's huge. It's probably the whole length of a table, and it's nice and big and has a head cut out and a belly cut out.
How much does it cost?
I didn't even look at the cost, to be honest. I think it's at least a couple hundred to $1,000. Any other questions?
Entire store, Center
Yeah,
Valley.
that's what it is.
What other questions, guys? Is that all? All right, thank you so much for listening to me talk. I hope it was helpful.
Just housekeeping, Jeremy, make sure you sign out on credit, and really make sure you pick up a certificate. Have a good one.
I don't think anybody has any questions. They all logged off already. Did I talk too fast? I had a lot to go through.
Maybe we can get a copy of your.
Yeah, absolutely. Thank you very much.